Let me just do some soft intro while people are still joining. And once again, thank everybody for joining. Particularly this time of year, it's a busy time for lots of people. My name is Michael Uhas. I'm an advisor to the Path Forward in the Mid-Atlantic as well as nationally. And I'll walk through in a minute a little bit more context of the Path Forward, but mostly just want to say thank you for joining. And as the group continues to grow here, we'll get started. So let's see. Sam, could you give me my first slide? And okay, good. Thank you. So the Mid-Atlantic Path Forward's lunch series is something we've just begun doing. So this is our first one. We're shooting for 3, potentially 4 of them this summer. And the whole idea behind them is to present organizations or allow organizations to present programs they've implemented in collaborative care with really a lot of focus on kind of the mechanics, how they got it up, sort of what motivated them and so forth. And I'd first like to thank Linda Raines, the CEO of the Mental Health Association of Maryland, and John Miller, who's the director of the Mid-Atlantic Business Group on Health, for really supporting and allowing us to have this series go on. And in conjunction with that, at the bottom of this slide, we'd also like to thank some of the sponsors over the past few years who've helped us really be able to get this kind of endeavor underway. The Open Society Institute of Baltimore, Leonard and Helen R. Stolman Foundation, and Johnson & Johnson all have been very generous in helping to fund our efforts. And a lot of these efforts have been really directed towards collaborative care activity. So we have, as I said, 3 sessions. We've set them up so they'll be 12 to 1 p.m., hopefully to allow the best attendance. We're talking about a lot of busy people. We figured at lunchtime for an hour, we probably have the best shot. Our presentations will be 15 to 20 minutes. We'll have 5 minutes then for Q&A. If we have additional time at the end, we'll also have some Q&A time there. We'll have an open chat session, but we're not going to necessarily stop and address all of the questions that come in. We are going to have them monitored. We'll get to some of them that we can. Others who are seeing questions come up and have an answer for them can feel free to answer. Otherwise, we'll try to get to some at the end. And as a last recourse, we'll be able to follow up with everyone who's attended the meeting and provide answers to questions that came up that we were not able to answer in the chat and during the session. The profiles of the organizations, we're trying very deliberately, as you'll see today, to have organizations that are somewhat different in their profile, different patient mix, payer mix, and so forth. Inside of Maryland, we're going to try for each of these sessions to have an inside of Maryland organization and one that's outside. There'll be different sizes, different populations, et cetera. And as I just mentioned, the focus is really going to be kind of how it really came to be, what it was like to get it off the ground, and of course, describing the program itself so that people have a sense of the scope and so forth of it. And importantly, the kind of challenges, the barriers, the kind of implementation and ongoing sustaining a collaborative care model, the issues that have been encountered and how they've been addressed. So Sam, if you could advance the slide. Just a word on the Path Forward. The Path Forward is a coalition. It's a national coalition that is supported by a number of very important partner organizations you see listed along the bottom of this slide. And the focus of the Path Forward is really to zero in on a few scalable, high-impact reforms that can help to improve access to mental health, substance use disorder care. And if you go to the next slide, Sam. This is just to depict how we have within the Path Forward initiative 8 different regional implementation sites or partners, if you will. They're basically coalitions that are local or regional healthcare purchaser coalitions. And in In our case, in the Mid-Atlantic, as I just mentioned, we have the Mid-Atlantic Business Group on Health and the Mental Health Association of Maryland. But we've got these in pockets around the country. And these serve as areas where we can try to really put into action a number of the things that the Path Forward is doing relative to policy, research, studies, data analyses, and the Mid-Atlantic Path Forward. Let's see, we've been around. I think you got underway in 2020. Is that right, Linda and John?
That is correct.
Okay, so a couple of years into it, and some of the others have been around for similar periods of time, about the same amount. So next slide, please, Sam. Today, we're talking about the collaborative care model as depicted here, and this is from out of the AIM Center. Most of you, or certainly many of you in this meeting today, will be familiar with it, where the primary care provider maintains a responsibility for treating the patient and works with the behavioral care manager to provide evidence-based medication or psychosocial treatments, and both are supported by a psychiatric consultant, typically a psychiatrist, but not necessarily, and works with the team to help make recommendations regarding medication changes in the treatment for those patients who are not really responding as expected. So we know that there are multiple ways of integrating care, and we're fanatically in support of integrating behavioral health into primary care. The Path Forward has zeroed in specifically on the collaborative care model, in large part because each of the kind of the areas of focus that Path Forward has taken in relate to where we are finding the strongest evidence-based models. And in our experience with collaborative care, with over 80 plus randomized controlled trial that have been conducted, all pointing in the same direction of improvements. We're not saying that primary care behavioral health model and other models are not good. We think they're very good. We just don't know. We don't have the database. We don't know how it compares. So this is what we're talking about today. We're not disparaging any other models, but I just want to clarify, this is the model that we're talking about today. Next slide, Sam. Okay, so for the session, each of you who have registered, actually everyone who was invited, should have received biographies on our speakers today. And we're going to have Sarah start off our discussion from the Primary Care Coalition, followed by Janelle and Mason, both from the Intermountain Health System. And again, we're going to try to have 15-20 minutes presentation, Q&A, and hopefully some more time at the end. So with that, I'm just going to launch in to asking Sarah to take over, and then we'll transition to Janelle and Mason.
And I, like you, Michael, have a pet who is not liking that my door is closed right now. So if anyone hears a crying cat, that is why. Has the door shut, so she may make a audio appearance. So hi, thanks for having me. My name is Sarah Frizzell. I am a licensed clinical social worker in the state of Maryland, and I'm the director of behavioral health programs at Primary Care Coalition. Next slide. So Primary Care Coalition of Montgomery County. So we are a nonprofit organization working with public and private partners to provide high quality, accessible, equitable, efficient, and outcome-driven healthcare services for low-income and uninsured residents in Montgomery County. So Primary Care Coalition does a whole number of different services. Today, I'll just be focusing specifically on the behavioral health aspect and our collaborative care program. Next slide. So for a little bit of background in terms of funding, and Montgomery Cares is a public and private partnership. So it's funded by Montgomery County Department of Health and Human Services, administered by Primary Care Coalition, and partnering with safety net healthcare providers in Montgomery County and other community-based organizations. So essentially what it does is it provides access to primary care services, specialty care, and behavioral health for residents of Montgomery County who are at 250% or below the federal poverty level and are uninsured. So the clinics are located throughout the county. So just for a little sense of the demographics, in fiscal year 22, 70% of the Montgomery CARES participants reported incomes at or below the federal poverty level, and 78% were Hispanic Latino adults of working age. So the services in Montgomery CARES include medical checkups, primary care, access to medication, lab tests, cancer screenings, and access to specialists. The next slide. So after Montgomery CARES started as a program, the clinics noted that there was a high prevalence of depression and anxiety among the primary care patients with Montgomery CARES. So we started the collaborative care model, the Montgomery CARES Behavioral Health Program, as Michael mentioned, based on the AIM Center at University of Washington. So currently we serve patients at 5 organizations and 8 unique sites. Next slide, please. So when we started the program, it was kind of a combination of the Georgetown University Department of Psychiatry, Primary Care Coalition, and as I mentioned, the Montgomery County Department of Health and Human Services. So initially it was called a project, and then later received status as a full program. So during the first 4 years of operation, the Georgetown University Department of Psychiatry conducted annual program evaluations. And in 2009, it transitioned from a pilot to a program. And then in fiscal year 2014 and 15, the program expanded, allowing it to further serve more partner clinic sites. Next slide. So our payment model is pretty unique, and I do think that has a lot to do with how we've been able to be successful. So we are not billing any insurance, including Medicaid or Medicare. We are just working with patients who have Montgomery CARES, meaning that we just get block funding. We also don't do fee for service. So this allows us a lot of flexibility in terms of kind of how we oversee the program, how we're able to implement, and not be as concerned with kind of the strict guidelines of different funding sources. So we've had kind of a lot of leeway in the amount of collaborative care activity we are able to do. As a lot of you probably know, there's progress being made, but traditionally it's difficult with insurers. And I'll talk a little bit more about that later in the slides. The next slide, please. So one of the things that we do is, I mentioned we don't do fee for service, but as we do report on our activities to the county. So what we've been doing since about 2018 is we have in our registry a way to track the number of times we do each type of activity and the number of minutes spent on those activities. So generally over time, we've spent about 2/3 of our time on collaborative care activities. So things like talking with psychiatrists, primary care, coordinating treatment, case management, and then about 1/3 on what we call more traditional billable behavioral health services. So evaluations and intakes, crisis psychotherapy, and psychotherapy sessions. And during the COVID pandemic, one thing that we've noticed that's interesting is it's shifted to even more time being spent on collaborative care activities. Our hypothesis is that some of that is just people have needed more case management, more access to resources like food, but we're continuing to track that to sort of see how that may or may not change. Next slide, please. So this is our staffing model. So kind of key to all our most collaborative care models, we have the behavioral health care manager. So on our team, most of the care managers are social workers. We've over time had nurses or counselors as well. So they're doing the coordination, the biopsychosocial evaluation, case management, short-term therapy, and all of our behavioral health care managers are bilingual in English and Spanish. Other times we have had staff who speak French or Amharic as well, because we do have a decent sized population who speak those languages. One addition that we have to our program is a community resource coordinator. We used to have what was called a family support worker, but had found that we really needed somebody who was able to kind of be a coordinator for the patients at all of our different sites. So what she does is really intensive case management for patients with complex needs. So she can do things like home visits. She can go with somebody to the court to sit with them as they're dealing with like be an intimate partner violence situation, a restraining order, can help with navigating kind of different applications, dealing with financial assistance programs, things like that. And then we have our psychiatrists. I mentioned we partner with MedStar Georgetown Psychiatry. We have a psychiatrist with us 20 hours a week, and most of her time is spent doing case consultations with the behavioral health staff and primary care providers. She also does educational sessions. We've been doing a series of monthly lunch and learns on different topics and invite clinic directors, nurses, MAs, behavioral health providers on topics like trauma, bipolar disorder. And then we do have her see a small panel of patients who may have complex medical or psychiatric needs. So I'll go a little more into depth on a later slide. We also have a psychiatric services coordinator. So I mentioned that all of our team is bilingual English and Spanish, the exception to that being our psychiatrist. I'm sure this is not news to anyone here. Finding psychiatrists is difficult right now. Finding bilingual psychiatrists is very, very difficult. So the way we manage that is we have somebody who does interpretation. And then this person also does administrative work, managing the psychiatrist schedule. Since during the pandemic, we started doing more telehealth. She sort of orients patients to how to use the technologies to do these visits and manages our program calendar. And then of course, the primary care providers. So they're screening and referring patients to behavioral health services and prescribing medication based on the recommendation of consulting psychiatrists. Next slide, please. So sort of our adaptations that we've made to the traditional collaborative care model, I mentioned that we have noticed a high amount of need for case management services. So that's why we have that community resource coordinator position. Traditionally, with collaborative care, the prescribing is done by primary care providers. That's largely true for us, but we do have our psychiatrists. She'll see some patients for maybe 1 or 2 visits just to kind of get them started on medication, or if there's some kind of lack of diagnostic clarity. One of the main reasons that we added that is that it's just been difficult to find resources when somebody has a need that might be just a little bit more complex than kind of an anxiety or depression. And finding somewhere to refer them to, especially if they're uninsured, is really difficult. So we've implemented that addition to our program. Traditionally, with collaborative care, anxiety, depression are the focus. We have a lot of patients who have experienced trauma. So we do focus on PTSD, acute stress disorder as well, and manage that. We also added a position called a supervisory behavioral health care manager. Because our team is pretty big, we added those positions to sort of oversee the work of the care managers, and that allows me also in my role as director to do kind of some more outward facing things, networking with other organizations, community work. So that's kind of an additional thing we added that's not necessarily part of traditional collaborative care. And then again, that we do require that our staff are bilingual in English and Spanish to meet the needs of the community. The next slide, please. So just in our outcomes, so when we first started in 2005, we were at 1 clinic organization. We saw 71 patients in the first fiscal year. Now we're at 5 clinic organizations, 8 unique sites, and we saw 1,368 unique patients in fiscal year 2022. Next slide. And just talking a little bit more about outcomes. So we do also measure quality measures. We have 4 that we look at, and we share those outcomes with medical directors and other staff to just, as kind of a collaborative, talk about how we can be implementing the model even better. So we look at percentage of primary care visits that include a depression screen, usually the PHQ-2 or PHQ-9. We count either one, whichever clinics prefer. And by having these discussions and measurements, we've been able to make improvements. So one clinic improved from 51% of visits to 84 in the last fiscal year. We also look at percentage of active patients with at least one documented depression screen in the past year. Again, we saw a lot of great improvement in that since we started to use those measures. We also look at the percentage of patients who do have a positive screen on the PHQ-2 or PHQ-9 to have a behavioral health visit within 2 months. And then, of course, we want to see patients getting better. So we also look at patients who've had significant symptoms of depression, so a PHQ-9 of 10 or above, with a demonstrated decrease in depression symptoms within 6 months of enrolling in the collaborative care program. Next slide, please. So some of the challenges that we've had, I've alluded to some of them. I think provider buy-in, it's a challenge. Some providers, you know, especially when we started, did not feel comfortable kind of managing behavioral health symptoms, or just preferred, you know, why can't every patient just see a psychiatrist instead? Over time, I think one of the ways we've worked on that is, I mentioned kind of these learning collaboratives where clinics will come together. And as we've had sort of champions at some of the organizations, like providers who are very comfortable prescribing antidepressants, kind of sharing their experiences. Also, you know, providing a lot of, I mentioned the educational sessions by the psychiatrist, as well as we've recently added some provider handouts that really go through each of the common medications. Okay, here's how you start sertraline, or here's how you start citalopram, the starting dose, the contraindications. Here's how you talk about side effects. So that's been helpful. We've also developed some provider talking points that we go over with providers. Okay, here's how to talk about the program that, you know, may not be an intimidating way for patients to access services. Here's terms to avoid. And we're always, you know, trying to set meetings with the clinics. Okay, what's working well, what's not, where are you running into issues, helping with workflows. So that's kind of one way we've dealt with that. Again, not news to anyone here, maintaining behavioral health workforce right now is really tricky, especially when we're looking for bilingual staff. I think one way we've dealt with that is trying to have robust connections with both undergrad and graduate social work programs, because a lot of times our best luck in hiring has come from hiring previous interns. Because they've had the experience, they've enjoyed working in collaborative care, and that's, yeah, often how we find people. So that's kind of one of the ways we've tried to manage that stigma of behavioral health. So, you know, we found that when a provider or someone else would talk to a patient, oh, you need to see a psychologist, or you have depression, doesn't go over well. Patients often don't want to engage. So we've really coached them over time to use phrasing like, you know, we have somebody here on staff who can talk with you about your stress or your insomnia or some of the things going on with your family. We found that that has tended to go better. It's less stigmatizing. And again, we're always shifting that. So we, you know, based on the feedback we get from people, from the providers, from the patients, we'll kind of adapt that. And then connecting to outside resources when patient needs exceed the scope of the Montgomery Cares behavioral health program. So, you know, someone with schizophrenia, somebody with poorly managed bipolar disorder, somebody with active, you know, substance use disorder, generally are not within our scope. And what we try to do is really maintain great relationships with some of the organizations overseen by Department of Health and Human Services or other community organizations. Again, I mentioned we have the supervisory behavioral health care manager position, which allows me to spend more of my time kind of doing that networking, relationship building, and community work. But that it definitely does continue to be a challenge that we encounter, but we try to stay up to date on, you know, new resources. We invite them to staff meetings so that we can kind of learn about what's going on. And next slide. And now it's time for questions. So that's a lot of information, I know, but I'm happy to answer any questions about our program.
Sarah,
Sarah,
oh, go ahead, sorry.
I was just going to share, Sarah, not a question from the chat, but a nice comment from Ben Peck. Thank you so much, Sarah and the PCC, for doing this work. This is so important.
No, great. Thank you for saying that. Yeah, we love it. It's not always easy, but it's yeah, we feel it's really helpful for the community we work with.
So, hi, this is Ben with a sort of follow-up question. I'm curious to hear what you found has worked around the provider buy-in issue. I've worked with primary care on trying to get them more engaged on behavioral health and the collaborative care model specifically, and I sort of found that providers kind of fell into two camps. There was kind of the one of like, yeah, that's part of what I do. Like I take care of my patients holistically. That is, and I love the help from a psychiatrist. And that other group that you mentioned, that's sort of like, yep, I do physical health, and please let me send them to someone and refer them just like I do a cardiologist. And to your point, there's not enough psychiatrists for us to do that. So we need to do this in a different way. So I guess what I'm wondering is, what have you seen works to help? I think there's kind of like, there's people in the middle. If you kind of show them how they can gain some more confidence around their ability to manage behavioral health, they'll kind of come with you on that journey. And I'm just wondering what you've seen has worked. Is it having peers like other primary care doctors who are just as busy as them, but find a way to engage? Is that what helps get those fence sitters off the fence and engage? What is it that you've seen works? I'm just curious.
Yeah, exactly what you said. We definitely have experience in kind of working with both types of providers. I think one huge one is just kind of the slow but important work of relationship building. So I think both kind of having that care manager make sure to have, a great way to relate to the providers. And that looks a little different at each site, but sometimes what we've done is really had the care manager, and this worked a little, better pre-COVID. We're doing kind of a hybrid model now, but, in the morning, like attending huddles, going around talking to each provider. Okay, do you have any patients today you're seeing, you're concerned about behavioral health issues, or what issues do you have? And then I think as some providers might slowly start to refer, I think they sort of see like, oh, okay, wow, like the patient having this one conversation with the care manager or starting this antidepressant, it's made a huge difference. So it's little by little. In some scenarios too, if we found that there's maybe one provider at a clinic who's more comfortable than others, we'll even suggest, okay, maybe the medical director could see this patient one time, they're more comfortable with it, and then transfer their care to those providers. It's sort of those baby steps that we've found has been the most helpful.
Yes, I have a question. I really enjoyed your presentation, and I think what you're doing in Montgomery County is very similar to what we're doing at Johns Hopkins in the MD-PCP program, which is kind of using the collaborative care model, but then also making some alterations. For example, we also have direct patient contact between the psychiatrist. The psychiatrist isn't purely consultative. A couple of questions that I had. First is, do you use measures in your assessments of treatment progress? And the second question is regarding therapy, psychotherapy. You mentioned that the social workers do brief therapy, which is what we had intended for our model. As it turns out, it's really hard for our social workers, our therapists to let go of the patients and, kind of, they develop caseloads, and that's not what we want to have. We want them to do brief therapy and then have the patient leave the caseload. So how do you manage, first of all, the measures, and then second of all, how do you manage the brief aspect of the therapy?
Sure, and that's great. I would love to learn more about your program sometime too, if you don't mind leaving me your contact info in the chat, because I love to hear about, what other organizations are doing with collaborative care. So yes, as measures, we at the first intake, we do kind of a set of a bunch. We do the GAD-7 for anxiety, the PHQ-9 audit for alcohol use, DAST for drug screening. We also do for psychosis. If indicated, we'll do the mood disorder questionnaire for bipolar disorder, eating disorder screening, the PCL for trauma. And then to kind of measure treatment progress, we do the PHQ-9 and GAD-7 at regular intervals. So we try to do them at least every 6 to 8 weeks to start, and as patients may become stable, we may expand that a little bit longer. And then the second question around therapy, yes, that is a hot topic for us as well. And yeah, we definitely have kind of the same challenges where we do have some patients that honestly have been in our program for a long time, which is generally not, the collaborative care model necessarily, but are just very used to that support, or, will have more long-term therapy, even if it's like one time a month. And it's difficult too, because our availability to do therapy kind of ebbs and flows. And seasons where we have a lot more referrals and are busier doing more intakes, we don't have as much time to do it. And sometimes like the summer tends to be a little slower for us, so people are maybe able to offer a little bit more of that, like sessions doing CBT, solution-focused therapy, motivational interviewing. One thing we have done is we've implemented more groups recently, which I think has helped some patients who maybe would be more interested in long-term therapy and were not able to offer it. We had tried in person in the past to do groups and didn't have much success due to barriers like transportation, childcare. We did a couple virtual groups, which were pretty well attended and pretty successful. And that was nice because patients were also able to sort of get that peer support. So we did a couple that we called like charlas in Spanish, like chats, to kind of remove the stigma of like a depression group, for example. So we did focus on topics like homesickness during the holidays, or the stress of parenting during a pandemic. We had like a wellness group where we talked about nutrition and exercise. So that's one way we've been able to get at a little bit kind of that need for therapy. But yeah, it has not been easy for us either. So we kind of grapple with that as well. And thank you. I see your contact info in the chat, so I'll be sending you an email.
Okay, thank you.
Could I step in here? I want to make sure that we have left enough time, and thank you so much, Sarah. And please, if there are other questions, please keep putting them in the chat. We'll follow up with people for questions we can't answer during the session. But I'd like to now transition to the Intermountain Health System, Dr. Mason Turner and Janelle Robinson. And once again, you have their biographies that have been sent out in advance, but I'm going to ask them to begin their presentation so we have time for questions, and anything we have generally at the end left, we'll take more questions. So Mason and Janelle, we'll turn it over to you guys.
Great, thank you so much, Michael. And we have a fair amount of content in our slide deck, Michael. So if you wanted to send this around to participants afterwards, it was designed with that in mind. So just so you're aware, we can certainly hopefully get to everything in the presentation today, but if not, you can feel free to distribute this deck as well.
Okay, will do.
Okay, so let's go to the next slide. This is just a snapshot of who Intermountain Health is. Some of you may be familiar with our organization, which recently merged with SCL Health out of Colorado. And so we're now in 7 primary states in the Intermountain West, so between the Rockies and the Sierras. And we're a fairly large organization with 60,000 plus caregivers, and we treat over 1 million select health members, which is our integrated payer plan, and about $13.9 billion in total revenue. So we have a large organization, but a lot of different concerns coming from different parts of our organization. So we'll talk a bit about that today. Now, I would like to start by just really going over our strategy. This is what grounds us in the work and really why we have been successful at establishing collaborative care at Intermountain is really because of our strategy. We are primarily, or at least half, VBC-based strategy. So we have value-based care in mind whenever we're implementing any new program, which I think to the previous comments around not having a lot of fee-for-service sometimes makes that easier, but we do still have to think about fee-for-service when we implement our programs as well, because about half of our medical group business is still in fee-for-service. But as we think about the future and moving to more value-based care arrangements, we have 3 pillars to our organizational strategy, which is to grow, cover more people. The people that we cover, we want to keep them well and really provide health, not healthcare, but health, and then provide the best care when needed. And collaborative care really fits into this strategy very well, and was one of the reasons that we were so successful. Next slide. Now this also, as we move into our behavioral health strategy at Intermountain, this really is a quote that grounds all of us in the work that we do, and we show this in the beginning of all of our presentations to really demonstrate why we're doing the work that we're doing. And this is a very famous quote from Desmond Tutu, which says, "There comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in." So this is really the orientation that we take. Can we understand how we can leverage our whole behavioral health ecosystem to keep people from falling in the river in the first place? When we think about our behavioral health strategy, we have 4 guiding principles that I think are so important as we look at our success with collaborative care. We have demonstrated with collaborative care how we can actually leverage these guiding principles to really bring more care to more people and keep them healthier. So first of all, we want our care to be consumer-centric. So whenever we implement a program, we try to think about what is it like for the consumer or the patient when they access our care services to be able to get to that service, know about it, and be able to access it and get better as a result of being in that program. And collaborative care has been, there has been no difference in terms of how we approach that and really thinking about how we make that as frictionless as possible for consumers to access. Of course, we want our care to be outcomes driven, including at the leadership level and really using outcomes to inform program development and selections. And then we also want our care to be innovative and equitable. If we then think about that as our vision, we have 3 core strategies that I won't go into a lot of detail with it. Basically, the 3 strategies are developing clinical models of the future. So again, how do we leverage innovation? How do we look at our current care delivery and make sure that we're providing the highest degree of evidence-based care we possibly can, both in specialty mental health as well as our integrated care programs? And then how do we leverage our community contacts and collaborations to be able to improve the health of the communities in which we're present and that we serve? So I actually came to Intermountain about 2 years ago. And when I came to Intermountain, we really had a new behavioral health leadership team that was put into place in 2021 with the idea that we wanted to really take a paradigm shift how we approach behavioral health care in the organization. And again, this is important because this paradigm shift is what really led us to be able to implement a collaborative care and be able to expand it as well. So first of all, and really importantly for this group to know that in our footprint, so the Intermountain West, has the highest suicide rate of anywhere in the nation. There's some differences from state to state, but in general, Nevada, Utah, Colorado, all of those, Idaho, have really high suicide rates. And we really wanted to understand how we could actually reduce the overall rates of suicide in our footprint. And it turns out collaborative care is an important part of that. We also had a lot of, I would call it pressure from our executive leadership to evolve behavioral health, to really look at our current programs and really be very critical of what we had done in the past as we look toward the future, because we knew that behavioral health coming out of the pandemic needs to look very different than it did pre-pandemic and going back 100 years. We needed to evolve and look differently at how we provided care. And a large part of that, I should say, is around implementing evidence-based practice, which of course, collaborative care is one of the practices in behavioral health that has the most evidence behind it. And so really importantly, looking at why we had done that to date and looking forward to why we need to do it in the future. There is a strategic focus that we've had that has become into clear and clear pictures around increasing value to patients and at-risk payer arrangements. So again, if we go back to the idea of value-based care and at-risk payer arrangements, behavioral healthcare becomes central to saving money in medical expense reduction. So that was part of our strategy. That it was really important. And then we actually had a funding request approved as part of a strategic funding request, and a pot of money set aside for that for our program startup cost, and collaborative care was part of that project. I won't go into this slide in any detail. This will be familiar to many of you on the call, but these are the reasons why we wanted to implement collaborative care. Intermountain has a very long history of integrated behavioral health care delivery and quality improvement, and in fact started those programs very, very early on before a lot of other medical groups were implementing them. So there's a very rich tradition of integrated behavioral health care, but we didn't have collaborative care in place, and that really seemed to us to be a huge miss and a hole that we needed to fill, because of the reasons that you see on this slide. And again, we've talked about the evidence behind it, really looking at proactive ways of managing mental health concerns even before a primary care provider might even know about them. But getting people better faster is really one of the reasons we wanted to actually implement this program. Now, if we look at our behavioral health care program in Intermountain in general, this will give you a snapshot of how we think about behavioral health and some of the levels of care that we have are either considering or that we currently have in place. All the way from management by the PCP only, use of digital resources that are a lighter touch, collaborative care, mental health integration, and I'll talk a bit in a few minutes about the difference between those two, outpatient behavioral health care, and then access centers and inpatient care as well. Our access centers are psychiatric urgent care sites that also serve as observation units and are really an important part of our spectrum of care. Again, thinking about those medical expense reductions and getting people access to care as quickly as possible. Now, I'm using the term mental health integration, which is a specific term for Intermountain. This is our original behavioral health integrated program that we implemented back in the 90s. And that program actually will be familiar to some of you, perhaps from some of your organizations, but this basically is a co-located care model with some consultation to PCPs, really designed to be short-term integrated care, a higher level of complexity of conditions that could be managed by PCP, range of insurance plans, and a lot of other aspects that will be very familiar to you. And of course, you all know about collaborative care. But the reason we actually think about it in these two different buckets is that mental health integration can be considered a higher level of care than collaborative care, allowing us to really have strong fidelity to the model in collaborative care. And then mental health integration can take care of those other needs that don't fit nicely into the collaborative care paradigm. This, I think, is very familiar from Michael's slides, as well as your own knowledge of collaborative care. And this is the model that we used in setting up our own program at Intermountain. And again, fidelity to the model of collaborative care, as had been demonstrated in evidence to improve medical outcomes, mental health outcomes, functional outcomes, cost savings, and so forth. That is what we want to implement and really look at the fidelity of the model as being key to our success.
Thanks. I'm going to jump in now. Just to add, at Intermountain, our behavioral health care managers, we are using social workers. We have a mix of licensed clinical social workers and clinical social workers that are doing their supervised hours to become fully licensed. Next slide. So collaborative care billing is different than traditional billing, which many of you likely know. You take the sum of the minutes spent in these coordinated activities and submit one charge under the primary care provider for the work of the team. And depending on how your organization has physician compensation models, that might help or hinder how the program can be implemented. At Intermountain, we have different compensation models based on the patient population that our primary care providers are serving. But among all of that, we do track RVUs as a basis of productivity for our primary care providers. So the RVU credit goes to the primary care provider because they are the billing provider of record. And this is something early on that we didn't capitalize on enough to sell the value to our primary care providers that there's also a benefit to them as well as the benefit to their patient. And under a single copay, there are multiple touch points to these patients throughout the month. And I'm going to go into that in a minute in the next slide. So let's move next. These are the CPT codes that we are billing. And even though we have strategically at this moment decided to only offer this program to our value-based patients, we are still dropping charges. And then that in turn passes on the patient portion of the expense to the patient. So we bill the $994.92 for the initial month, and then the subsequent months we bill the $994.93 with any additional add-on codes for the additional time being spent. And you can see there the RVU credit that goes to a primary care provider for each of those codes and the approximate expense to the patient. Next slide. We did a bit of analysis trying to build the case both to the patient and the primary care provider of the value that is provided through collaborative care from a cost perspective, as well as a touch point perspective. So what you see in the top of this slide is we anticipate about 3 months worth of collaborative care. And if the patient was seeing the primary care provider in between, we modeled out in this example 2 primary care visits with their primary care provider. You can see that would be about 14 RVUs and about $1,600 worth of expense to the patient. Whereas if we did a traditional referral to a psychiatrist and a therapist, with approximately the same amount of visits, there would be additional expense to the patient, as well as the primary care provider would not be receiving RVU credit. So this was part of what we learned through our implementation of how to engage the primary care provider in this work, both from a patient perspective as well as a primary care perspective. Next slide. On this next slide, we then tried to create a comparison talking point for our patient. So explaining to them, if we refer you to a psychiatrist for an evaluation and we refer you to a social worker or psychologist for an evaluation, you would get approximately 120 minutes at approximately $576 of cost. Where in collaborative care, you get the best of both worlds. Your primary care provider gets the input of the psychiatric consultant. It is not face-to-face for the patient to the psychiatrist, but the same, but that consultation provides that level of support, psychiatric support needed. And then the multiple therapy touch points provides an opportunity to have more time spent and at a lower cost. Next slide. So just to clarify, who are we including in our collaborative care today at Intermountain? We started 1 year ago, and I have some stats that we'll share in just a minute, but we currently are offering for 18 and above, and we are holding true to a clinical model of patients need to have a PHQ-9 or a GAD-7 score of 10 or above, and they need to be participating in an at-risk payer. We are excluding, you can see the exclusionary criteria there. So we do have a specific population we're working with today. Next slide. Just our referral pattern. The primary care provider places a referral in our electronic medical record, which then goes to our care manager who reviews. Based on that, they have a conversation, including a consent conversation with the patient. Once the patient gives a verbal consent, we do have care coordinators who are unlicensed staff members that help do lower level work. So we are keeping our care manager working at the top of their license. So they're doing scheduling, helping with phone calls, and an integral part of our team. Once they consent and enter into the program, they get the treatment as defined by the collaborative care model. And then when ready, we unenroll them and close out our episode of care within our electronic medical record. Next slide. So registry, let's talk about registry. We have a Cerner product. And when we started this, the consultant we were working with to help us launch said, we've never successfully used a registry in Cerner. And we worked very hard with our data team to figure out a way to use our existing tools to have a registry to help guide our work. So our Cerner product goes into a data warehouse, and then we use Tableau to query our data warehouse to pull in a dashboard that is our registry. So you can see we have our patients here. We have the enrollment date, the total number of minutes, total number of contacts, and then we do have some conditional formatting based on if there's a need to reach out to a patient or a concern. You can see the colors pop so that it does guide the daily work of our care managers. So in terms of data, like I said, we started a year ago, actually last August, and we started small and we're continuing to grow. So we have served 313 patients so far in our program, and we have now set up phases of implementation, and you can see the clinics that we have. One clinic is in phase 3, which we consider our fully optimized kind of maintenance phase. Phase 2 is a past initial implementation, but still needing to optimize, still needing to increase registry sizes and have additional provider engagement. And then our phase 1 are in that initial implementation phase where we're working very closely with them to optimize the future of the program. Next slide. So we look at data weekly to see how we're trending in terms of enrollment, right? The key to successful collaborative care is having those registries full, and we are not there. We have had a learning curve, as any organization will tell you. It takes a minute to get this up and running, but what we have found is keeping track of where we're at, having targets, has really kept us in a forward momentum. Dr. Turner, back to you.
Great, thank you, Janelle. And just we have a couple more slides, and then we certainly can take some questions. This is just a snapshot of some of the outcomes from the program. And as you can see, we had 24% remission rates, which I am particularly proud of, because that actually means that we got 24% of people into full remission from their illness, which is great. And you see the response scores there as well. Next slide. We are expanding to endocrinology, actually our diabetes clinics, that will launch this month. More primary care clinics, additional women's health clinics. We will be looking at a pediatric implementation as well. That'll be a little bit different than what you just saw, but will be very important. And then we will be having a dashboard that's in development to really help to guide some of our leadership decisions around the program. And this is our last slide, and I would just talk a little bit about our challenges and lessons learned. So I think some of the challenges, again, managing a change in our organization was actually a pretty big deal for us because of the long legacy of integrated behavioral health care we had at Intermountain and have at Intermountain. We really had to manage a lot of change and explain why we needed this program and why it was different than the existing programs. And I think that's gone very well, but that had to be done very intentionally. So I want to really point that one out as one of them. We also have a very complex system. We are a large company with a lot of different clinics and a lot of different leaders and a lot of different caregivers working in different sites. And pulling all of those stakeholders together was very complex. That was a very complex task for us. So I would say those were probably two of the bigger challenges from the leadership perspective. And then the usual issues of clinic engagement, really trying to understand turnover issues and things like that. We actually had a fair amount of turnover at the beginning of this project. And so we had to manage those issues from the outset. Some of the lessons learned, let me just go through a couple more on that slide, and then we'll open for questions. A couple of the lessons learned, I would say that any group that's wanting to implement collaborative care, bring it up to speed quickly and a really high fidelity to a model, really think about using an expert consultant. We actually invested some funding in doing that, and it's probably the best decision we made along the way with this program, to be honest. And then I think really understanding the role of the PCPs, having champions at the clinic level, and also case finding through universal screening is important. Okay, we'll open up for some questions.
Thank you very much, Chanel and Mason. And once again, our apologies for those of you who did not get their bios. We're resending them to people. But we now have a few minutes left and see some chat questions, but let me open it up to questions that haven't been answered yet in chat.
So Laura, on your question with the pediatric, we expect to launch with depression, anxiety, and ADHD. Sorry, I was not clear in the chat. So we're looking at those 3 qualifying conditions for our pediatric launch. But to be fair, we're still in development and plan to launch later this year.
There was a question in the Q&A from Brittany that I don't know that we can answer right now unless someone from the Maryland Primary Care Program is on. The question was a billing question. Would billing for these services be duplicative of the care management funds received under MDPCP? So if there's someone from the health department that could answer that, great. If not, we'll get that question answered after today's event.
Hi, it's Christina from MDPCP. It is not duplicative because you would use your care management funding to cover patient expenses. So if you hired the employee into your practice, then you could use the funding to cover their salary. But if it wasn't a direct hire, then you could bill the insurance under the PCP.
I'm seeing a question from Dr. Carlo, follow-up question on patients excluded from the calculations in response and remissions.
Yeah, let me address that one. Sorry, I was not clear. So it's not just completed, it's inactive. So we include all patients, whether they successfully complete or just turned inactive. We are including both of those in our denominator.
Good. Other questions before we end the session? Well, thank you all very much. Again, it was our first attempt to pack this into an hour, but Sarah, Janelle, and Mason have done a phenomenal job. Thank you for doing that. And remember that we will have a second session coming up on August the 25th. So we are lining up and finalizing the presentations for that now. Laura Willing had asked early on in the presentation about pediatrics. And we are fiercely interested in that. And we are, again, looking at presentations that we can present from Maryland as well as outside of Maryland. And so we're taking recommendations on these series. Depending on how much interest we get, we can continue doing these for some time. We love doing it. And particularly given the new legislation in Maryland that passed this year, allowing for the reimbursement of collaborative care under Medicaid, we are anticipating the interest level to spike. And the Path Forward and the Path Forward MidAtlantic specifically want to be able to do whatever we can to help facilitate that. So we will be sending out follow-up responses that did not get addressed. If you have additional questions, please get back in touch with, just send them to the Mental Health Association. You can send them to me for those of you who have my address, but we will make every effort to get these answered. We're also these sessions are recorded, so they're going to be posted on the Mental Health Association, the Path Forward website within the Mental Health Association site as soon as we can get that together. And any questions in the meantime, please forward them to the Mental Health Association where you got the original invite. But thank you so much for taking time, busy time of year, and really appreciate it. Hopefully everybody gained something from this session. I certainly did. Thank you all.